We need that keyboard. Hey, good morning, everyone. This shouldn't take more than an hour, actually, so we should be fine. Alrighty. Can you hear me back there? Okay. Okay. So this block, this lecture today, it's going to be about joint and ligament injuries. Okay. So they divided it in 2 hours, but I can talk for 2 hours, but I mean the topics doesn't need all that time. So I just put it in one lecture, and then we're just going to talk about the main joints and the common joint and ligament injuries. Okay. طيب. You know, we have many joints in your body, and each joint is unique compared to the other one. The most common thing, like the type of joints, like we have a hinge joint, like the elbow, a hinge. This one or this one? Should be this one. Should they be like this? Okay. Okay. طيب, the type of joint. Okay. The type of joint that we have that's very common, like the knee and the elbow, is like a hinge joint. It's like the edge of a door. When you open the door, it's hinged. So for example, like you have the elbow and knee, and you have unique type of injuries to these type of joints. So if you know the type of joint, you would know the type of injuries that you might have. And then we have the other common type. It's the ball and socket, like the hip and shoulder. Okay. So if you have a ball and socket, that means there's a labrum. Okay, if there's a labrum, that means there might be a dislocation. That's a little bit. Any joint can be dislocated, but the dislocation kind of way, it's kind of you would appreciate the feature or the way of the joint, how it would dislocate. And there's like a saddle type of joint, like for example the first CMC joint. It's like a saddle where it just have a few motion over top the other bone. And then there's a gliding pivot type of things. But we're going to talk, this is just a general information about the type of joints and then the type of injuries we have. For example, in a hinge joint, you would have a lot of you would rely more on the collateral ligaments. Like for example, the knee, you have the LCL, MCL. The elbow, you have the MCL, LCL. And then the ball and the socket joint, like the hip and shoulder, you have labrum, and the labrum has really a very important role to prevent the joint from dislocating. Okay. Alrighty. So the word joint and ligament injury is very broad. Okay. So I'll just try to make it as simple as possible for you guys. Okay. So these are the most common joints. We have a lot of joints in the body. Each joint can be injured, can have a joint injury. What I mean by a joint injury, we're talking about intra-articular type of injury, like articular surface injury, depression, fracture, whatever close to that. Or you can have ligamentous injury, okay? Whether it's intra-articular, like an ACL, PCL, or extra-articular, like for example, MCL, LCL type of thing, especially around the elbow. So the shoulder has unique type of injuries, the elbow, hip, knee. We're going to talk about these main joints in a sec, okay? Any question in general, or just proceed? Okay, you guys hear me well now, right? Okay, it's kind of uncomfortable. I'm just trying to be like this. Alrighty. So before I talk about each joint specifically, how would they present? Okay, so most of the time when I have a joint injury, ligamentous injury, the etiology most commonly will be a trauma. This is one of the things that can happen. But if for example, if I have arthritis, they will not present as an injury rather than a gradual pain. So it's a degenerative process. So the way they present and the joint and ligament type of injury depends on the etiology, and usually in trauma it's very acute. You would appreciate what type of problem we're dealing with. Is it pain? Then we have, because now things kind of overlapping with the previous lectures that we gave. This is like approaching MSK trauma, like we talked about. You do the history, you do the physical examination, you have the main differential in your mind, and then you just eliminate, rule in, rule out stuff based on the thing that you're suspecting. Okay, so etiology, what I mean by that is if you have a problem or a pain, this is the main thing that the patient would come to you in the clinic. Then you approach that accordingly, okay? And in this lecture, we're going to, I think most of the things that we're going to talk about here are trauma, because I can relate to the joint and ligamentous injury that I want to give you today based on trauma. Okay, how to approach these injuries? Again, we talked about it: history, physical, and investigation. You can do labs if you're suspecting septic joint. You can do X-rays if you're suspecting fracture. You can do both if you're suspecting inflammatory arthritis or a trauma, and they can overlap each other. Okay, and then how to manage these things operatively and non-operatively. We're going to talk about each joint alone, so you can, because not every joint is the same. Alrighty, so shoulder. Shoulder is very. I do like my main practice is shoulder and elbow. So I do a lot of upper extremity surgery. So I remember one of my mentors told me, the shoulder is so complex and it has a lot of problems. That's why you have a job, because it's the most mobile joint in your body. You can move it in all directions, and based on that, you can have a lot of problems with that. You can have, these are the main things that you can see in a joint mainly. Okay, you can see things that can be out of that. But look, for example, rotator cuff tear. It's a very common pathology in the shoulder. Okay, labrum, which what I mean by, and instability, they can be together, which is dislocation. Okay, you can have the AC joint. There's a problem with that. You can have the bicep problem, and then impingement. Impingement, what I mean by that, it's a kind of a rotator cuff problem, but this is how it starts. It's the acromion impinges over the rotator cuff, and that's why they have pain, and then they have inflammation, and they can progress to tear. Okay, so the shoulder joint can have soft tissue and can have bony problems. Okay, so if you want to talk about the joint, it can have a fracture, like any trauma. We showed that proximal humerus fracture. It can extend to the articular surface. It can have a joint injury. It can go to the glenoid as well. Okay, it can happen. You can have arthritis, like any other joint. Any joint is prone to arthritis. Different wear, different pattern, but it's the same principle. Okay, necrosis, AVN. It's not as common as the other joints, for example, but it can actually, no, sorry, the shoulder AVN is actually common. It's more, you can see it in the hip and the shoulder. It's not common in the elbow actually, but you can see it around the humeral head, and it causes a lot of pain. And sometimes the only solution for that is you do replacement, especially for the young population with sickle cell disease or post chemotherapy and so on. So avascular necrosis is one of the joint injuries that you can see. You can have a septic, any joint is prone to be septic. Okay, so when a septic process or a sepsis occurs in the joint, there is a destructive process that happens in the joint. That's why we need to investigate that, rule it out, and then treat it accordingly, because the more we wait on it, the more destruction can happen to the joint. Okay, and then now moving to the ligament and soft tissue. Okay, so again, you have a glenohumeral dislocation. I've been specific with the glenohumeral because if you tell me a shoulder dislocation, AC, the acromioclavicular joint can dislocate. The glenohumeral joint can dislocate. The sternoclavicular joint can dislocate. Okay, and these terms kind of like it falls under the shoulder dislocations. Okay, but to be specific, glenohumeral dislocation is the most common thing that you all know. That when the ball leaves the socket. Okay, and when it leaves the socket, imagine the amount of destruction that can happen to the ligament and soft tissue. So usually in elderly population, they can have dislocation, but commonly you see with them rotator cuff tear because the cuff is really fragile. And then once they do that, the cuff is torn. The young population, the cuff is strong. So when they dislocate, they have a labrum problem. Okay, so the treatment is different between both of them. When I treat a young person with instability, I do labral repair. When they treat somebody with a dislocation in the older population, I do rotator cuff repair. So understanding this is, again, the presentation, etiology, age, population, and everything is unique for each patient. Okay? So the glenohumeral dislocation is very important. And other injuries can happen. So it can have a fracture dislocation. So it can have a joint injury and ligamentous injury at the same time. Okay? And then you can have AC separation. Okay, so back to the glenohumeral joint. So the most common thing, you have anterior dislocation, you have posterior dislocation, you have inferior dislocation. Okay, the most common one is anterior dislocation, more than 90%. And usually how it happens is when the arm is out. So abduction, external rotated. This is why when somebody dislocates like this, the safe position for them is they put a sling and they put their arm across their body. So if they don't have a sling, I tell them, like, listen, after dislocation, and they're really afraid because they become apprehensive, I tell them, listen, if you go into a crowd, just touch your belly and just be like this. This is a safe position for you. Unlike the posterior dislocation, where they dislocate an internal rotation. So after surgery, or if we want to maintain that, we put them in a special type of brace where their hand is like this. There's a pillow underneath, and then their hand is like this, neutral position, a little bit externally rotated. Knowing the mechanism of injury helped me how to treat the patient, okay? Because when you have a dislocation, you have the ball, you have the socket, and you have the labrum, which makes the socket a little bit deeper. So anybody with a dislocation, the labrum has to be affected. And then they have a Hill sac problem, okay? What I mean by a Hill sac, it's an impaction injury. So the ball comes out, it hits the edge of the glenoid, okay? This is called the Hill sac. If it goes to the back, which is dislocation, hits the glenoid from the back, this is called reverse Hill sac, okay? Hill sac is an impaction injury to the ball that's coming out of the socket and just touches or impacting on the edge of the socket itself. And then when you go out, definitely the labrum will be crushed. So that's why they have a labral injury. And some people will have more injuries to that, but this is the most common thing, Hill sac and labrum. It depends on the type of dislocation that the patient has. And then we treat that accordingly. And then the other one, you have AC separation, okay, the acromioclavicular joint. The most common way for this to be injured, usually, so most of these things I'm mentioning, the main etiology is trauma, because this is the most common thing you can see. Sepsis can happen, arthritis can happen, but the way they're gonna present, usually either acute presentation with other things like fever, pain, tenderness, blah, 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 or they will have a gradual pain. However, in trauma, these things can be presented. So they fall down, it's a direct hit to the shoulder, and then the AC joint separates, okay? And we have multiple grades of separation, okay? It's not for you to appreciate all of them, but the AC can be separated, ligament can be injured around this AC joint, and then we treat it accordingly, okay? Sometimes we have to reduce it, sometimes we leave it, depending on the degree of separation. And then you have the rotated cuff pathologies. It's one of the soft tissue problems that I see very, very, very common in my clinic, okay? Whether it's a partial tear, I'm sure that everyone here has a relative with a shoulder pain. And some of them, they know what's the diagnosis, some of them, they don't know, they just have always pain. They always say, this is my bad arm, they use the other arm. So it's either can be partial tear, full tear, inflammation, subacromial bursitis. It's multiple etiologies that present with pain, especially with motion, okay? Anything about the shoulder? Okay. Elbow. I like the elbow joint. A lot of surgeons, they don't like it. Either you like it or you hate it. Nobody because it's a complex joint, okay? And the outcome, if you don't appreciate all the pathology around the elbow joint, the outcome cannot be predicted, okay? What I mean by that is, for example, if you don't understand the trauma itself and the stuff injured around the joint and not fixing it at the time of presentation, patient might have problems, stiffness, stuff like that. So you didn't do anything to help the patient. Okay, so in terms of joint injuries, you can see you can have a fracture. So any fracture around the elbow can extend to the articular surface. You have a joint injury, you can dislocate the elbow joint and have a fracture dislocation or just dislocation. Okay. Which I mean by that is the radial head. So as you can see here, the elbow joint is formed by the radiocapitellar joint and the ulnohumeral joint, okay? So the ulnohumeral joint is the hinged part of the elbow, okay? And then usually the glenoid and the capitellum, it's kind of the relationship, it's like an axial load type of thing and just rotation, pronation, supination. That's the main thing with the elbow joint, okay? So type of problem that can happen, you can have a fracture to the distal humerus, extending to the articular surface. You can have a fracture to the proximal ulna, extending to the coronoid. You can have a fracture to the radial head. All these are joint injuries and articular surface injuries as well. You can have arthritis. You can have rheumatoid osteoarthritis that can happen to any joint, okay? Again, they will present gradually and then you would appreciate it with the approach that we talked about. AVN, not that common, okay? But it is something that I would investigate if everything else ruled out and I would suspect in a patient with high risk factors. Septic, again, any joint is prone to that. Ligamentous injury. So as I told you, like any hinge joint, for example, if I have like two sticks, okay, and then I just do the type of thing, the metal, to make it a hinge, okay. So this type of thing prevents me from one plane. Like I can't go all the way to the back because the hinge joint, the bony engagement prevents me from going all the way to, for example, full extension. So it helps me, doesn't go all the way flexion, okay? It gives me an arc of motion, which is functional, painless. However, it doesn't prevent anything the other way, like on the coronal plane. I can do this, I can do that. That's why you have these collateral ligaments on the side. That's why you have an injury. That's why you can see it in the knee. That's why you can see it in the elbow. So usually people who plays baseball, they always have an MCL problem because they do this type of coronal type of stress on the joint, and then they stress on the collateral ligaments, okay? And some people with the type of injuries, they can have LCL, especially when they fall down on an outstretched hand, okay? So you can have LCL and MCL, and it's a complex pathology that but need to be appreciated. It comes with that, whenever you have a trauma, fracture dislocation, ligament injury, you can have the common extensor. This is not a CO or a CFO of a company. This is common extensor origin and common flexor origin, okay? These are things also can provide some collateral protection to the joint as well, okay? These problems explain the golfer's and tennis elbow, the common extensor, the common flexor. You have a tear, you can see, for example, here. This is, it's very small here. You have a tear in one of the common extensor, okay, and every time they use their hand, they're just in pain, okay? So every time you use your hand, these are all the muscles attached to the lateral epicondyle, okay? And if you have a small tear or inflammation, every time they use their hand, they just wanna raise a pot of tea, or they wanna raise a cup or whatever, they're just in pain. They wanna carry their purse, they're in pain because they're just moving this and there's a lot of stress on that tendon. So this is one of the most common problems in MSK pathologies in general, tennis and golfer's elbow, and the etiology is it's the extensor tendons and the flexor tendons, tennis and golfers respectively. And one of the other soft tissue that we see commonly around the elbow is the triceps and distal biceps, okay? So triceps in the back attached to the lacrimal process, okay? They can have a rupture. So I've seen that usually in people who are for example, renal dialysis, people who are using steroids, injection like that, they can have this type of tendon injuries, and they can have a triceps rupture. And part of the thing we approach MSK trauma is part of your physical examination. If you suspect something, do the physical exam that tests this something. For example, you're suspecting triceps problem. Tricep, what does it do? Extension. So I would ask the patient, okay, I know you have pain. Can you just push on my hand here? Well, it's very weak. Okay, can you go against the gravity? Well, actually, no. I feel there is actually a gap. Same thing with Achilles tendon, same thing with a quad. You're testing something, you have a specific pathology in your mind, and then when they're just feeling, and then passively it can go all the way up. So this is mechanically, it gives you the idea of there is something, it's not pulling. Okay, so triceps can happen, and then we fix that surgically as well. Same thing with the distal biceps. Okay, the good thing about distal biceps, they will still be able to flex. Because the main job of the distal biceps is what? Exactly. It's a strong supinator. So imagine, like, extend your elbow and supinate. Do that. Like you're screwing something to the wall. Okay? How you want to make it a strong grip? Flex it. See the difference? So that's why somebody who's a worker, they want to try to reach something, they have to be close to the thing, and then they do this. So they have a good control of that over that. And then if you touch the biceps belly, when you flex your elbow and do this, you see it. It's kind of it's migrating up and down. It's doing its job. Okay, so it's main supinator actually rather than flexor of the elbow. Again, if I know the function of that, usually is somebody comes to me with a distal biceps injury. I tell them, okay, flex your elbows, go pronation, supination, and they look at the biceps. Is it going up and down? Okay, I try to palpate for the biceps. This is the biceps tendon that you can. This is the hug test. You can feel the biceps. Okay, if it's ruptured, then I can't feel it. And then if they're weak with the supination, again, I'm suspecting something, and then I'll move to the MRI or ultrasound to confirm my diagnosis. So distal biceps and triceps is common tendon injuries around the elbow, okay? Any question about the elbow? Alrighty, moving to the wrist joint. So wrist joint is I know it's a small joint, but it is a complex one as well. Okay, I know every joint is complex. The most common joint injuries that we can see, you can have a fracture around the distal radius. Okay, distal radius is very common. It can be extra-articular, can be intra-articular, as we explained in the previous lectures. It can extend, and then it can be really, really annoying. And then carpal bones can be fractured. Each carpal bone is just formed of articular surface. So Any fracture is interarticular fracture to the carpal bones. It's just covered with articular surface all over. It's not like the distal radius, only one part and the rest is not. So the most common thing is a scaphoid fracture. It's a very, I wouldn't say very common, but it's common and it's critical injury. Look at the scaphoid as a part of, what do you call it? I forgot his name is English. Satur. You know what ters? What is ters in English? Oh, I forgot. Huh? Yes, exactly. So you have multiple gears, okay, attached to each other, okay? Scaphoid is one of the gears in a whole system. If that scaphoid is fractured, the whole system is collapsing. That's why if a scaphoid injury, we do CT scan, MRI, even if it's a small hairline fracture, I need to make sure that this thing not missed out. Because once it collapses, they might go into AVN, okay? And they might go into collapse, and they might actually displace with time, and then the whole joint become orthopedic. And you see this in the young population. They go play in, do whatever they want, they have pain, you do x-rays, nothing, and they go back and they still have pain. After 1 year, you're doing x-ray, you see a little bit of changes around the scaphoid, you do CT scan, MRI, oh, that's a missed fracture. What to do? Actually, you just began the process of this orthopedic changes. Can I do something? You try. But it's very important if somebody comes to you with a scaphoid pain, you need to rule out. And usually how we test for that history, physical examination, part of the physical examination, you palpate the scaphoid tubercle. This is the scaphoid tubercle. There's something that's really bumpy in your front of the joint, just below the thenar muscle, okay? This bumpy, this is scaphoid tubercle, okay? Snuff box. Remember snuff box from anatomy stuff, okay? This is the people, they said for snuff box. I've never seen a junkie that do that. They just have the credit card and then a table. Nobody uses the snuff box anymore. But this is the snuff box. This is if they have pain in that area, this is where the scaphoid is. So I'm gonna hold in the scaphoid here. Somebody has pain and you have low index of suspicion, just do a CT and MRI, pull that out. So scaphoid is very important not to miss. Other joints that they can be injured, but these are the most common thing. Ulnar head can be injured as well, but scaphoid and distal radius are the most common thing. You can have arthritis. Rheumatoid arthritis tend to affect the wrist as well, and it can be septic as well. Okay, in terms of ligament and soft tissue injury, there's a ligament between the scaphoid and lunate called the scapholunate ligament. Okay, and this can be injured in certain type of movement. Okay, sometimes if you do a certain movement, rotation, or you fall down, you might not necessarily fracture the scaphoid, but you can injure the ligament attached between the lunate. And then if this ligament is injured, you know the gear system I just explained to you can be also affected, because the relationship between the lunate and the scaphoid is usually the scaphoid and the lunate, when you flex, they go together and they go back together. If this relationship is gone, then the whole system is kind of collapsing, and then you're going to have the same problem similar to scaphoid fracture. Actually, there's a classification for both. It's not for you, but just for you, for whoever is interested. If you have a scaphoid problem that you miss out and the patient go into a collapse, it's called a snack wrist. Scaphoid in the union advanced collapse, snack. And if you have a ligament problem called the slack, scapholunate collapse problem. So snack wrist, we have snack 1, snack 2, snack 3, snack 4. It's not about food anymore. It's a classification that really affect the wrist and hand. And then you have a slack. So the way I'm telling you this is because it's very important to know these pathologies, and it doesn't take much for you to rule in or rule out at the time of injury. Some people, when they come to you with this pain, they say, you know what, it's just nothing. You don't treat it like a small hairline fracture of the forearm or the humerus that can be managed inoperatively. You need to make sure, because it has a high risk of AVN, scaphoid fracture. That's why we kind of annoying about it, okay? So the other thing is the dredge, distal radio ulnar joint, okay? This is the dredge. This is the dredge. See that? This is the dredge. Distal radio ulnar joint, okay? So this is an AP view of a distal radius. You see my cursor, right? Yeah. So this is an AP view of the dredge. This is the relationship between them. And usually in the lateral position, you see a good overlap. So that means they're not volar or not dorsal, okay? This is how the dredge usually should be situated. Some people can have subluxation, some people can have dislocation, injuries that can have effect into the dredge, okay? And usually when you do an AP view, you will see like something is weird here. And you see the lateral position, you see how this is kind of dorsally placed? And when you examine the patient, you see it's kind of mobile. When you examine the contralateral side, it doesn't go away. Actually, it's moving a little bit. And the other side, the affected side, is actually whoa, it's kind of moving a lot. Okay, so these type of things that you need to appreciate, and this is a common problem that you see, usually associated with distal radius fracture, or it can happen isolated. Okay, and then you have the TFCC. It's a very long name. It's the triangular fibrocartilage complex that you see here above the ulnar head. Okay, usually seen in young population who do weightlifting, who go to the gym, who are active, and then when they have pronation, supination, they have this ulnar-sided type of pain, this here, and it can happen due to sudden movement or lifting something very heavy with this type of rotation, and they can have injury to the TFCC. It's the whole complex here. You can have the radioulnar ligament, and then mainly it's the meniscus that we have here above the ulna. So there's the meniscus above the ulna that can be also injured. We do an MRI and then we treat it accordingly. Okay. So this is mainly for the wrist joint. Okay, going now to the lower extremity. Okay. So hip joint is it's a ball and socket, as I told you, and can be dislocated. But usually it's a dislocated hip is not like a dislocated shoulder. Okay, it's an axial loading joint. It's a weight bearing joint. Okay, so you need a good force and a really bad trauma for the hip to be dislocated, and not that commonly you can dislocate without a fracture. You always have the acetabulum to fracture. Okay, it's kind of deep into the bone, so for it to dislocate, it's not that easy to pull it out and then dislocate, like the shoulder, for example. For it to dislocate, it can sometimes it just fractures the bone. Okay, that's why they have a posterior wall acetabulum fracture, and they have sometimes neurovascular injury to that. Okay, so the femoral head can be fractured. Okay, not common, but you can see it in young population with high energy trauma. Okay, and then you can have acetabular wall fracture. Okay, these are all joint fracture, interarticular fractures. Okay, it can be arthritic. It's a weight-bearing joint, so arthritis is more common, especially in active population. And AVN. So AVN, this is the most predominant area of AVN in somebody who's prone for AVN. For example, if somebody with a sickle cell disease, they can have AVN all over the body. If they have it around the hip, they will be in pain, really, really in pain, because the weight bear on it. Okay. They can have it around the shoulder, but the shoulder they can put it in a sling and that's it. They use the other arm or whatever they can do what I hear. But the hip, you're just loading it every time you walk. You can't be not walking all the time. So that's why it's very demanding. And that's why you see people in young age, they go for total hip right away. You can see people with 25, 30, sickle cell disease, they go for total hip replacement. Okay, septic, as I told you. Ligament, so the labrum can be injured in the hip, actually. I know this is sometimes not new, but there is labral pathologies in the hip, and people, they do arthroscopic hip surgery to repair the labrum, for especially athlete people. So it can be seen, and usually we investigate that with certain type of investigation, physical exam investigation, and so on. And then the other thing that can cause also hip pain and not bony problem is the tendon. So you have a lot of tendon passing around the hip joint. Okay, especially for example the iliopsoas. The iliopsoas, you see here the iliopsoas. I don't know if they have it here. Yeah. So iliopsoas, they all pass and they attach to the LT, the lesser trochanter, the lesser troch of the hip, and then it's a big hip flexor. So it's really adherent to the hip joint. Sometimes it can cause pain by doing a lot of compression on that. And there is a lot of the rectus femoris, the reflected head of the quad, also all around the hip, and they can cause pain. So tendons that passes around the hip joint can cause pain around that. And then you have other pain generators around the hip, which is not the hip joint, for example. Pubic rami fracture, there can be a problem with walking and rotating. Pubic symphysis pubis, can be pain, especially in pregnant lady who they just gave birth and they just have widened of their pubic symphysis if they give vaginal delivery instead of cesarean section. They can have pain around that area because it can be inflamed, can be stretched out. And also they can have pain around the sacroiliac joint, okay? Again, any joint can have pain, but we're talking about the most common thing today. Okay, anything about the hip joint? Okay, knee. This is where a lot of surgeons, they make a lot of money, okay? Because they have They need the knee, and it has a lot of injuries, and now it's the sport era, so that's why it's becoming focus. So, so you can have a joint injury and soft tissue injury. So the joint injury, you can have a fracture. So this is the joint, okay? So this is the condyle. So one of the fracture that can happen, you can have fracture to the condyle, you can have a fracture to the patella, and you can see the posterior surface of the patella is articular as well. Okay, you also can have a fracture to the plateau, which is the upper part of the knee. Okay, these are things that can happen with a trauma and can happen with a fracture. And then again, one of the most common type of arthritis is knee OA. Okay, so you can have an arthritis, you can have rheumatoid arthritis, and can present with arthritic changes, narrowing of the joint, as we talked before. And then there's something that also you can see in other joints, but it's commonly seen in the knee. It's called the OCD, which is not the OCD, it's called like it is the osteochondral defect or osteochondral dissecant. It's basically, I think you have a picture somewhere. Yeah, here. So part of the articular surface, it just detaches itself due to whatever trauma. Sometimes it just not attached very well. It can happen sometime with athletic person. Part of the articular joint, it can be defected, and this can be progressing. It can progress to arthritis if it's not managed properly, because you're going to have a rough surface inside the joint. So this is one of the things that you can see, like an OCT lesion. We do an X-ray and you see part of the articular surface. It's kind of not in a good shape, and you do an MRI and you can see this thing. It's kind of coming off. You see it in the condyle commonly, and you can see it in the ankle as well. So OCD is something affecting the osteochondral component of the articular surface of a joint. Okay, and it can detach itself from the joint, and the joint becomes not congruent anymore. And this is a problem. Okay, and septic joint, as I told. Okay, so ligament. So the most common thing that you guys see is meniscal injury, right? Okay, usually people with meniscal injury, how does it happen? Come on, you guys are athletes. Or or I just want one word. Huh? No. No, how does the injury happen? Yes, twist. So this is the type of twist. So basically, that's why when we try to examine for meniscal injury, is we ask them to squat, because when you squat, there's a small twist that is naturally happening in the joint for the joint to lock in. This is part of the basic mechanical stuff that happens in the joint. And sometimes we do some type of test, they just put weight on one leg and they just go to the other way. You want to twist, because once you grind this meniscus, if they have pain, they will have pain, and then it becomes significant. So this is very important for meniscus. We have medial meniscus and we have lateral meniscus. Okay, and it's a little bit different from each other in terms of anatomy and the most common type of injury. Okay, meniscus is the cushion in the joint. So when somebody is arthritic, that means there's no meniscus anymore. Okay, and this is very important. Okay, so this is for meniscus, and you can see here, see this picture? So this is lateral meniscus, and this is medial meniscus. And you have a tear there, especially in an athletic person, it's becoming a problem. So they do surgery arthroscopic and they fix it, okay? In an elderly population with meniscal problem, they're still not arthritic, we don't do anything to that. We just try to leave it by. And then the other thing is the ACL. So usually ACL it's more common in females than males, even athletic, due to soft tissue laxity. They're more prone for the ACL injury. And usually, how does it happen? Most of the time, it's due to the awkward landing that happens. This is what they teach players, how to be protective when they're just escaping an attack from another teammate member or somebody who's just sliding underneath them. The way that you land, you need not to land in an angulated way. This is where the ACL can happen, and then the ACL is responsible for the relationship between the tibia and femur, the distal femur. So it translates to the front. So if you have an ACL injury, it will translate more. If you have a PCL injury, it will translate back. So this is very important to appreciate. And this is what they teach. So in sport medicine rehabilitation, one of the major things is injury prevention. I don't want the injury to happen to tell you, no, you shouldn't do that. So one of the prevention is to be fit and to avoid this awkward type of landing, to avoid this type of injury. So ACL also can happen with a bad twist. So that's why you can have meniscal and ACL injury at the same time. Okay, and usually it's a worse prognosis than just only one of them apparently.
So what about the injury that comes with abrupt stop? So you're running and then you suddenly stop.
You can have.
Is it facing?
You can have, because it's again, it's about the relationship between the distal femur and the tibia. So any translation injury, you see it actually. I don't know if you see these videos in TikTok and Instagram videos, whatever. They see you somebody who's just like putting a lot of eccentric load, and then suddenly the knee becomes like this. So any type of these injuries, like it's a one plane. You're talking about sagittal plane deformity. So this can happen. Okay, so this can yes. So how would they present? That's the question, okay? Because ACL can come or meniscal injury or nothing. So they'll come to you with pain, right? One of the most important things that you need to ask a patient with a possible ACL injury is, did you continue play or you're stopped? If it's that serious, they wouldn't continue play. They will be limping and they will be in a lot of pain. Or they will be said, you know what, it's just this one thing, and then they continue to play. That's number one. Number two, immediate swelling or not. ACL has some feeding vessel with it. So if it's torn, there will be a lot of hemarthrosis. So they will have immediate swelling, unlike other interarticular injuries. Like meniscal doesn't have, because there's some part of the meniscus that doesn't have direct arterial supply. So it doesn't have that much of a bleeding like an ACL. So when a torn ACL, somebody had like immediate swelling because it's bleeding inside, or they couldn't continue playing and so on. Then at that time, you cannot examine them because they will be in a lot of pain. Okay. Once you suspect this is just from the phone, I can suspect that. Oh, this happened, okay, sure. Well, let me see them. Put an ice on it and let me see in the clinic in a few days. Once things settle down, then you do the specific test for meniscus, you do specific test for an ACL, and then you do an MRI for that to rule in or rule out. Okay. So for ACL, there's the anterior drawer test. Okay. I don't know if you guys have an clinical session with orthopedics this year or the next years. You guys, next year, okay. So I want to give you a lot of advanced information, but usually called anterior drawer test. Is basically the patient is laying down, okay, on the bed, and then they bend their knees. And then usually what I do is I sit on their foot, and then because I need to stabilize the tibia, and then I hold the tibia and with both thumbs on the anterior part of the tibia, and then I just pull it towards me. If it comes all the way to me, then I'm suspecting something. Some people will be lax, so it will come. So you go to the other side and compare. And then you do this type of things if you suspect. If you push it in, it goes, this is more PCL. So posterior drawer test. So anterior drawer test, posterior drawer test. There are a few other tests that you do for meniscus. So if you're suspecting this, you do an MRI, and then you have this all suspicion, and then it guides you to the injury. Is that clear? And then you have the LCL, MCL injury. Again, it's a coronal plane problem that they can have in ACL, LCL because of the awkward landing. Something will be stretched out, and then you examine with palpation around the joint because LCL, MCL you can palpate it. ACL is a little bit deep, meniscus is a little bit deep, but you can appreciate it. But LCL and MCL is a little bit easier for you to palpate. So if you're suspecting that, you will examine them with a stress. So you hold the knee. This is my hand. For example, patient is lying down. This is the left leg, okay? So my head is behind the posterior thigh, and I'm holding the leg, okay? And now I'm doing varus stress, right? You get me? Varus. So I'm stressing the lateral compartment. If it opens up, there's a problem on the LCL. If I hold it and then pull it away, I'm doing valgus. So if it opens up, I have problem with MCL. Same thing we do with the elbow. MCL, LCL, okay? I don't go all the way with the knee extended, okay? Because with the knee extended, there will be a bony engagement. So it's gonna be difficult for me to examine the ligament isolated ligament examination because the bone will be locking. So I need to flex a little bit to unlock the bone and just test the ligaments alone. So do this, do that, and then this gives you an idea. All these give you the suspicion you need to do an MRI. Okay, X-ray and then MRI after that. Okay, capsule. I mentioned capsule here because there are many injuries that can happen around the knee, and part of it is capsule. So there's something called posterolateral corner injury, PLC. It's very common and it's very bad injury. That part of it is the capsule. So capsule can have also some stability around the joint. Okay, I'm not going to go into a lot of detail because even this is sometimes fellow level for this, but just for you to know, ACL and MCL and PCL and LCL is not the only ligament that can be injured in a joint. Okay, there are a few other things, including the capsule, that can make an injury very complex. Okay, and there are a few players actually in our league, they have this type of injury. I can't actually disclose their names. They're struggling with that type of injury. Okay, and now you can have the tendons around the joint. So you can have a hamstring injury. Okay, usually it's the posterior muscles that you can see around the hip. So you can have a proximal injury, you can have a distal injury. Okay, and so this is usually affect the patient from becoming more flexible, running, and just having this abrupt type of movement around the games, and this is very important. So hamstring injury can happen with a sudden antagonistic effect of the other bone, of the other muscle. Quadriceps, for example, here, it's above the patella. It can be injured. Same principle the triceps, same principle the Achilles tendon. Can happen. You can feel a gap. Accessory mechanism is lost, and then you go on. Same thing with the patellar tendon. So this is a quad here. This is patella. Patella can be inflamed. Same thing with the quad. Can be ruptured. Can be painful, and can cause a lot of problems around the joint. Okay. Alrighty, so now moving to the last joint of the day. So we're talking about the ankle. So the unique fracture that we see, you can see lateral malleolus fracture, medial malleolus. So this is a normal joint. So that's the lateral mal, medial mal, and the posterior part of the distal tibia. Posterior part is we call the posterior mal. Okay, so somebody can have a trimal fracture, which is a very unstable joint. Okay, that has to have surgery. So people can have only a lateral malleolus fracture, okay? People can have only medial malleolus or can have bimalleolus fracture. This is a common injury, especially with twisting. So if somebody twists their ankle, it's easy to get these type of bones that coming here and there. So you can have this type of injury. And you can have also trimal if it's a really bad fracture. Again, ankle it can be arthritic, it's a weight-bearing joint, okay? OCD is common, you can see it merely around the talus. So the distal, the femoral condyle is a common place for OCD. The talus is a common place for OCD as well, okay? And then it can be septic as well. And then you can have ligamentous and soft tissue injury, for example. So you can have an ankle ligamentous strain, or the famous word like you can have a sprain around the ankle, okay? So it can be the sprain is no tear in the ligament. So you can have a sprain, you can have a partial tear, you can have a full tear. And people, how would we know that? We don't do an MRI for somebody with an ankle sprain right away. If they said, you know what, after that injury, I feel my ankle is a little bit weird, and we do special testing for the ankle to see if they're unstable or not, they will tell you, I've been tripping a lot. Something is weird. So you do an MRI and you find that they're deficient. They don't have the ligament anymore because they torn everything before. Okay, so this is what we suspect, and usually we suspect the ATFL, the anterior tibiofibular ligament, and the deltoid. So ATFL is just the lateral ligament, deltoid is the medial ligament, which attaches the medial malleolus. So these can injure with somebody with a bad twist to the ankle. They didn't fracture the bone. I wouldn't, and they have a lot of swelling. I would suspect ligamentous injury because they can't get away without anything. Okay, and the other one is the syndesmosis, okay? Syndesmosis is another ligamentous injury around the ankle, which is mainly involved in the relationship between the lateral malleolus, the distal fibula, and the distal tibia. This is the syndesmotic area, okay? So it can be injured in an ankle fracture. So when I told you like people can have a bimalleolus fracture, they can have a bimal bony problem. The deltoid ligament and the ATFL can be still preserved, but the syndesmosis can be affected. How would I know that? Usually is I need to fix it in the surgery when I do that. So we do special testing to see the syndesmosis. So again, when we have a pattern of injury, I have to suspect everything and I have to test it accordingly because I can't fix it at that time. And then move to that. Okay. So syndesmosis is part of, you can see the interosseous membrane, and their extension is kind of the syndesmosis. And then you have the ATFL, which is just around that area. So the ATFL is not completely lateral, it's just anterolateral around that area. But it's a common ligament that be injured in an ankle sprain if it goes very bad. Okay. So how we would demand these injuries, I told you, like in each fracture, usually shoulder dislocation, for example, you treat it in an op, you reduce the joint in emergency, and then you put it in a sling for 1 week, you start physiotherapy, you say, okay, so the labrum is torn, there is a Hell sac lesion, can you accomplish something with physiotherapy? Well, this lesion cannot come back. I mean, cannot be recovered completely, but I do physiotherapy to strengthen the muscle around it, and hopefully they wouldn't have dislocation again, okay? The problem with glenohumeral or shoulder dislocation in general, there are two paths for any glenohumeral dislocation. One-time dislocation, which can be managed with physiotherapy, blah, 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 or recurrent dislocation. Recurrent dislocation needs surgery because with multiple dislocation, you can have arthritis. One time you can dislocate and get stuck, fracture the humeral head, and that's a bigger surgery. Sometimes you can dislocate and hit the brachial plexus. So recurrent dislocation, it's a pathology that needs intervention. One-time dislocation, I can't argue with the fact that you don't need surgery. We can do physiotherapy and watch it, play it by ear, and then see how it goes. Okay, so this is very important distinction that I have to make with the glenohumeral joint. For elbow, usually the most common thing is dislocation. Again, not very common, but I mean, this is something that we see when you have a dislocation without a fracture, when you check the ligament, unstable or not. The key thing about elbow is range of motion. Whatever you do, you're gonna treat it and up, range of motion as early as possible because they get stiff very fast. If you put your arm in a cast for 2 weeks on your elbow without anything, you'll become stiff, unlike any other joint. So that's why if there's a fracture, I need to fix it right now so you can range your elbow right away to avoid the injuries. For the wrist joint, the most common thing that we see is distal radius fracture, and then most commonly we see it in the elderly population, and we treat it non-operatively, especially if it's not interarticular fracture. If it's displaced badly or young population with a lot of interarticular involvement, then we treat it surgically. Okay, hip problems. If you have a hip fracture, usually it's surgical. It's very rare to see a hip fracture, even in the sick patient. We treat it surgically because they need to walk. By the way, I told you that in the hip fracture section before. They need to walk on that hip, okay? And they can have a femoral head problem. They can have a dislocation in the young population. This is surgical, and this is sometimes it's an emergency. In the knee, you can have fractures, which also surgical emergency because they need to walk on it. And you can have ligamentous injury, as we explained. It's a very common sport injury that you see. The most common thing is ACL. And as I told you, immediate swelling and immediate pain, inability to play after that gives you the hint of the problem they have. Twisting type of injury, awkward landing, and so on. Ankle, the most common pattern of injury is the twisting type of thing. And with a twisting, you can have ligamentous, you can have bony fracture, you can have both. All can happen with that. Okay? Any questions about joint and ligament injury? You guys are experts now? Okay, thank you. Okay, we're good. I'll leave it for you, Ryan. يلا شكرا. I'll text you next week. Usually I pass by the hospital.
Later. Let's see who's gone. Well, do you want to mark someone else?
Yes, just for the girls, not for the boys. Is it okay? Yeah.
Yeah, it's okay. Is everyone there?
Wait. What? 220. 22009. No.
Is that true? Yeah.
How's everyone going?
Zain Umer what?
No, check.
Maram, wait, I'll mark. Wait, let me do the guns first.
Present. Mom's not coming. What the fuck is gonna record?
You want to do?
201 482.
201?
482. Thank you.
No worries. What's your ID? 211?
Nothing.
Alright. Maram, what's your name? Maram. Did you record?